So in 2018, when her cancer had progressed on the capecitabine, we'd gotten a partial response from the capecitabine, and we were thinking about other options. We chose the Eribulin because there's randomized trial data from the Embrace trial to say that it makes overall survival better to choose that agent over another agent of the physician's choice. That studied standard dose Eribulin studied standard dose Eribulin versus treatment of physician's choice like vinorelbine or gemcitabine or one of the other regimens, even capecitabine. The overall survival was better in that trial, which was great. The time to progression was better, and the tolerance of the drug was very good. So that was a good choice in that point. Other choices would be to switch to combination chemotherapy, which I wouldn't necessarily favor because of the reasons I stated just a little while ago, where the doublet and triplet combinations are more toxic than single agent. So I would pick a single agent next. Eribulin's a great choice because of the overall survival benefit, but vinorelbine and gemcitabine and other single agents that are approved for breast cancer would have also been reasonable choices for her. Just as long as you're paying attention. Now, my general rule when I'm treating metastatic disease is that if the cancer responded to one treatment, it has a good likelihood of responding to the next treatment. There are certain numbers of regimens that are available, so I try them sequentially until it's obvious that the patient has a cancer that's become resistant to most chemotherapies. So when I have a patient who's had cancer that has progressed through one endocrine therapy and they go on chemotherapy and they don't respond to the first one, you see disease progression when you check scans the first time, the chances that they'll respond to the next one are pretty low. So I usually try to pick something with a different mechanism. If they don't respond to that one after the first 3 months of scans, then that's a really poor prognostic factor. And then we start talking about clinical trials for sure, which we talk about all along, but then also the option of hospice, because some of the studies now have shown that hospice and really aggressive palliative care to keep the body in good shape, keep people around longer than trying to keep giving them cytotoxic therapy that's toxic to the body and isn't controlling the cancer. The Eribulin toxicities most commonly are low blood counts or cytopenias and neuropathy. There are some other rare side effects like fatigue. I haven't had very many people get stomatitis, but it can happen. So when someone gets low blood counts from Eribulin, the practice is to decrease the dose. So you wait until the patient's blood counts recover so that their neutrophil counts less than grade 1, and they're safe to get another dose, but then decrease the dose to the next down dose level of 1.1 milligram per meter squared from 1.4 milligram per meter squared for the 2 weeks in a row. And then monitor blood counts every single dose of Eribulin so that you make sure that they're safe getting the dose. The same is true for any other grade 3 or 4 toxicity that is experienced during treatment. So the common toxicity criteria are used. And if they have mouth sores, grade 3, and they're not eating well, then the treatment gets reduced too. We also dose reduce for hepatic dysfunction and renal dysfunction.